Hello, everyone. I'm Taylor Alston Cleveland, and welcome to our Health Legacy series presented by the First Lady's Health Initiative. Today, we're diving into a critical topic, the gaps in postpartum care and how they contribute to maternal mortality and morbidity amongst Black women. We're so honored to be joined by three incredible women who will bring powerful insights and lived experience to this conversation. So kicking things off, we have Dr. Shars Chambers, also known as the Period Doctor. She is a proud Spelman graduate and a board-certified OBGYN. She earned her MD from the University of Alabama, Birmingham. Dr. Chambers is also a new mom, and she's very passionate about advocating for Black maternal health, bringing both professional expertise and lived experience to this conversation. Thank you so much for joining us today.
Thank you for having me.
Our second guest joining us today is Alex Symington. Alex is a seasoned healthcare leader with over a decade of experience driving community health and advancing health equity. She is a proud Spelman alumna and holds a master's in health administration from Indiana University. As the former director of community health at IU, Alex led statewide initiatives tackling hypertension and maternal and infant health. Thanks so much for joining us today, Alex.
Thank you. Glad to be here.
And lastly, we have Dr. Shalonda Sunshine Crawford. Dr. Crawford is the co-chair of the First Lady's Health Initiative LA chapter, serving as the First Lady and co-pastor of The Experience Christian Ministries in Los Angeles. She's also a licensed psychologist and nationally recognized mental health advocate who truly brings light, compassion, and truth wherever she goes. You might also know Dr. Sunshine on KBLA Talk 1580 or from her powerful book, Employ Your Pain. Thank you so much for joining us today.
Such an honor to be here. Thanks for having me.
So now it's time to get real, to really get a handle on what this postpartum journey looks like and what's happening to Black women as it relates to maternal health. I want to share a few statistics with you all and with our audience. According to the CDC, Black women are 3 times more likely to die from pregnancy-related causes than white women. And multiple factors contribute to this, including quality of care and underlying conditions. Also, income disparity doesn't fully explain this issue. According to the New York Times, even the wealthiest Black mothers and their babies are twice as likely to die as their white counterparts, specifically in California. And lastly, postpartum care models often fail to incorporate culturally relevant practices and support systems that are really important to many Black communities. So again, these are some really heartbreaking statistics. So I want us to dive into this a little bit further. So let's get started in our discussion. So to start this off, I want to hear from each of you. When we talk about postpartum care gaps, what does that mean to each of you? And would love it if you can share it from your perspective, both from a personal perspective or even from your work experience.
Personally, postpartum care gaps look like, who do I follow up with? What's next? There can be some fragmentation as it relates to how care is delivered in this country. When we are super specialized and people are focusing on their shift and that patient in the moment, that handoff and that continuity isn't always there. That can certainly affect Black patients. It can certainly affect patients that don't have as many resources. And so what I had to do, a lot more than I thought I would need to do when I was postpartum, just say, well, then what? Who do I see next? Well, what happens after that? And so it is, unfortunately, the burden of the person or the patient to really continue that conversation, because even though I'm with you in this moment, my life continues, my risk factors continue. And so that was a major aspect of gaps that I've seen personally.
How about you, Alex?
I completely agree. From a health administration standpoint, when you have a patient who is postpartum, they're going to their postpartum visits with their OB, and then there's not always that handoff back to primary care to continue managing their chronic conditions. Yeah. So I think there needs to be better coordination from a health systems perspective to make sure that the journey for a patient is very smooth.
Great. Anything you would add?
Yeah, so as much as I definitely agree with the panel here, I think from a mental health perspective, it feels to me like the gaps center more around interpersonal and cultural community struggles.
Yes.
And the struggle is really normalization. I think the gap is in normalization as far as how you feel, the way you think, the emotional connect or disconnect that's happening between mother and child, and just kind of normalizing the full experience. Some mothers, do well in bonding and connecting, some mothers don't. And we don't always have access to good information
Yes.
to help us navigate the mental aspects of that experience.
Yes, I'm really excited to dive into the mental aspects too in this conversation. So to expand on that, when it comes to postpartum, the postpartum period is often overlooked when we talk about maternal health overall. Why is it so critical to have conversations like this, especially when it comes to the Black community?
I believe in the Black community, there can be opportunities to bring to the forefront our experiences, right? And so sometimes when we're thinking about healthcare, we don't see ourselves reflected. We don't see ourselves reflected in the pamphlets, in the literature, in just the posters that are on the walls. And so when we can talk about it and say, this is something I've lived, I think it puts a face to it, it puts a name to it, and it says, hey, it's okay if I experience this too. There's community here. This isn't something that happens to others. This is something that I personally could deal with. This is something I can have a village that supports me with. And I think sometimes we need to bring it back to our community and say, hey, this is something we go through too.
I completely agree. I think that when we talk about the gaps for Black women in this journey postpartum, it's exactly what Shars was saying, that these are conversations that are not happening in clinical settings or in community settings. So people don't know what's normal. They don't know what to expect. And then that mental health piece is so critical as well. People are often suffering in silence. And I think that postpartum depression doesn't present the same way for Black women that it does for white women. And so I think this is why it's important to be raising awareness about these types of things and the resources that could be available in the community to support the not only physical but mental and emotional journey for women postpartum.
I 100% absolutely agree with everything that's been said. First off, yeah, we're not seeing ourselves in information that's out there. So it's a little bit isolating from the beginning. We can't touch and connect and label and know that what we're dealing with birth, postpartum, is not unusual. So we feel like we're on an island by ourselves. And there are three things I think we're missing. So one, I think there does need to be more awareness that this is not an issue that's outside of you. Two, I think we need to create access points once we get the information. How can we then actually grab hold and get the help that we need? Podcasts like this, checkpoints, and community access really helps. And then three, I really think in the Black community we have to do more of this, having open, candid, authentic conversations where we can normalize the struggle. So many women go through this and they just don't know it's a normal phenomenon. It's a normal thing. It's more normal than not.
Right.
In many instances. Yeah.
Completely agree. And Alex, you said it, suffering in silence. This is a way for us to remove kind of the barriers and remove the stigma around it. So just to drill down, just from a clinical perspective, I read off some really tough statistics. From your perspective, what is causing the maternal mortality rates that we're seeing?
When people talk about maternal mortality in a more general sense, the main top three contributors, so cardiac disease, hemorrhage, and hypertensive disorders, those are all technically preventable, meaning we can modify those things. We have enough protocols and understanding that we can meaningfully intervene so that outcomes are improved. The issue, a lot of the time, is related to bias that can be on a provider level or even, obviously, a systemic level. So it's one thing to say, if you have these types of symptoms, let us know. It's another thing entirely to say, I actually believe you, or I value you,
Yeah.
or I'm going to partner with you to get you the help that you need. Even provider bias has been shown in how and if they ask questions. How and if they ask, how are you feeling? Do you feel well today? Just those sorts of things, that little bit of curiosity that's often tied to love and understanding. It's not always there when bias is present.
I want to actually build on this with you, Alex. So she mentioned the systemic issues. Can you speak to how social determinants also play a part in the intersection between maternal health and postpartum care for Black women?
Absolutely. Social determinants of health directly impact a mother's ability to recover safely after childbirth. It impacts everything from standard postpartum care to managing chronic conditions. And I'll walk you through a very common scenario that we see in healthcare systems. You might have a patient who is going back to her hourly job 6 weeks after delivering because she can no longer afford to be unpaid and not working. When you're an hourly employee, if you don't work, you don't get paid.
Right.
And often you're living paycheck to paycheck. So you've not had an opportunity to save in preparation for your maternity leave. So at this point, you might be going back to work already behind on bills. You haven't paid your rent, your car note, maybe electricity, and you're struggling trying to figure out, what can I afford? And so food, that would obviously be a priority, but we see with inflation, the price of food is very high. And a lot of people are living in food deserts, so they don't have access to healthy food.
Right.
And so you can kind of see how all of these different factors play together to really impact someone's ability to take care of themselves, let alone their baby. And I think the other piece I want to highlight is transportation, because if you are relying on public transportation, which a lot of patients do, it makes it hard to make sure that you can be at your appointment.
Right.
And if you are unable to pay your phone bill, then you can't notify your clinic if you're going to be late or if you need to reschedule. And again, you have to be mindful of your hours at your job. And it's hard to take off in the middle of the day
Right.
to go to a clinic appointment when you're working an hourly schedule. So I think society doesn't make it easy for the most vulnerable mothers. And then, when you're back in a hourly setting, you don't always have the ability to pump. And we know that lactation is really the preferred method for nourishing your baby. And so you can kind of see how not only is the mom who's now in a work setting stressed about the bills, you're still dealing with your hormones and emotions and probably lack of sleep too.
Right.
Then you're going into a work setting, you're not able to breastfeed your baby. Your baby is now not getting the preferred nourishment, and it really creates a cycle.
It's a cycle. And just emotionally
Yeah, draining.
navigating that.
It's so hard.
Your perspective, Dr. Crawford, again, you wear so many hats, so many great hats. But as a psychologist, diving into kind of that emotional piece, how has your journey or maybe the, conversations that you've had kind of shape how your view on kind of this conversation and Black maternal health and some of the social determinants that Alex just mentioned?
When I hear the stats that you read off about the disparities happening specifically in California, where income, your whole economic situation is not a barrier. I didn't know that stat. And honestly, it triggers me on a very personal level. It's hard not to lean into the systemic issue that you're referring to. I have a lived experience, a personal lived experience, and perhaps it's just kind of resting and leaning on the systemic issue that I've had to live personally. But as a psychologist, I've sat in therapy rooms with mothers who are silently suffering on the other end. And again, feeling like something's wrong with me. Something's wrong with my child.
Yeah.
Something perhaps is wrong with the environment. Why am I not connecting? And that, in and of itself, can be a devastation that is passed along. Do you know what I mean?
Right.
And when you think I'm not bonding with my child, and you question yourself as a mother or question the child that you birthed, there's a lot of psychological and environmental hazards that we would have to look. And then it just creates more, I don't want it work, but heavy lifting.
Yep.
And
Yep.
as Black women, we're already burdened with psychological heavy lifting and
Right.
overwhelmed. We're already overextended. We're trying to work out some of the social issues that you've described and still having to balance the balls and keep things hanging. So we're overextended, we're
Yeah.
overloaded, we're overwhelmed, and often misunderstood at the same time.
Absolutely.
So, yeah, from a psychological standpoint, there's a lot at risk.
Yep. So I want to actually go back to you, Dr. Chambers, because you've built such a powerful online community around reproductive health. I'm curious, what are Black mothers and Black women telling you on your platform as it relates to postpartum care? Are there any themes that you're seeing that you can share with our community?
Yeah. I think a major theme is, but I knew this. Like, as in, I knew something was wrong. I knew this wasn't supposed to be this way. I knew something was off, and not getting that validation. A lot of what I do online is take general health information and center Black women, because we don't have the benefit of being centered, the majority of the times.
Yeah.
We're always on the fringes. Oh, you're Black? Oh, let me see if I can adjust this. Even AI, if you put something in there, it's more likely to just show like a white mom. It's like, oh, actually, I need a Black mom. We know that we're always considered under the other. And so that adds an added layer of, I don't know, stress and heavy lifting to say, well, how do I see myself in this? And so what I've learned and what I've seen from a theme standpoint is Black women saying, I knew this, I saw this, but I wasn't seen.
In addition to what you're saying, I'm Dr. Sunshine, right?
Yes, you are.
But in many instances, moms come in, feeling like there's a dark cloud over the whole entire situation. And having someone or some people or a village to let you know that your feelings are valid.
Yeah.
And you can come in and be loved, not judged.
Yes.
You can come in and know that, you can still struggle and be in therapy. You can, you can still be a whole person, and for that matter, still be in Christ and struggling a bit. So the struggle doesn't make you abnormal. That validation is what's needed. And when I hear you say, sometimes we're going into care and we're not being asked the same questions.
Yes.
If you prompt me correctly, I can give you more accurate information.
Okay.
But if you're not asking me, have you guys ever heard, sometimes you don't know until you know?
Right.
Have you guys ever heard that? You don't know
Yes.
until you know.
Right.
And I know for me, oftentimes I don't know a thing until you bring it up.
Yeah.
Right.
How many times have I heard in a therapy session or a therapy room, I was a little sad, but I didn't know to say something to my doctor. I thought, let me just get up and, spruce myself. I didn't know that there were options for me to explore. Right. So if doctors aren't asking, how are you feeling? Honest, the baby blues is common. So are you feeling a little down? You know what I mean? So those are the things that I think we're missing: validation and information that's given to us proactively, because we don't always know.
Correct. On that point, Alex, you have led a large team of community health workers to address postpartum care gaps. So I'm curious, what has been effective at the grassroots level that you've seen?
Absolutely. So I led a team of community health workers, and that's quickly becoming a very common role in healthcare systems to bridge the gap between the providers and the community. And community health workers function very similarly to a social worker, but they don't have to have all of the education and training. They're often from the communities that they serve, and so they have an understanding of the struggles that our patients might be experiencing. They're not far removed. Okay. Maybe they grew up in the same community, going to the same church, also struggled with transportation at one point, and they're resourceful. They want to make a difference. And so we hire community health workers to provide emotional support, resources, and education. And when you have someone that looks like you, that talks like you, there to help, you're able as a patient to have more trust. And there is a real problem with distrust among the Black community when it comes to healthcare.
Correct. Yeah.
And so the community health worker can be that confidant that you can maybe share some things with them that you wouldn't necessarily feel comfortable telling a doctor in a white coat that's not even giving you eye contact, not even asking kind of the follow-up questions that you would want as a patient. And so they really have been making a difference in the communities by being that trusted source.
I love that.
And can we add to that the lack of trust in the medical community is not a made up folklore, but it is rooted in actual truth. I mean, we all know about the more recent Tuskegee experiments, but we can take this back to the 1700s with yellow fever. And I'm sure we can go back even further than that. So I think part of the reason why these types of conversations are important is because there should be some validity inside of the truth of our mistrust and distrust and all the trust things that are out there.
Yes.
Absolutely. So there's a lot of work to be done.
Definitely. And that's, and when we think about our organization, our First Lady's Health Initiative, that was something that we wanted to address, the lack of trust.
Yeah.
And a lot of times, whenever we would have our health clinics, that's often someone's first time getting their blood pressure taken. That's often someone's first time getting a health screening. And when you're meeting someone where they are in a trusted environment where they feel safe, that makes all the difference.
It makes all the difference. But more importantly, and just to add to that, when someone feels like, I don't trust you, and then they are being made to feel like that distrust is not valid, that worsens health disparities.
Yes.
There was an article in the New York Times that talked about how Black people just don't trust the healthcare system in the United States. And what they really should have said was, let's talk about the historically valid distrust that Black people have of the medical system of the United States.
Yes.
And when you tell me that there's not a valid mistrust issue in the United States, and when you make me feel like this is about me and my inability to connect with you and trust you, it has a direct impact on your mental health because it has an impact on the way you see yourself, your self-image, your self-identity, and it makes a pathway for you to have to now deal with whatever the issue is you're dealing with your doctor.
Yes.
And then the mental health issue that was just created in that moment.
Absolutely. And there's actually research. There's a study that shows that if you affect a certain generation of mice, for example, and there's like a smell, like a raspberry smell, and then something bad happens, subsequent generations will panic at that smell because it can be encoded into your DNA to recognize situations that are not safe. And so it doesn't even have to be an intentional response. It can say something in me, the ancestral blood that runs through me says that these halls aren't safe. That someone that walks in the room like this isn't safe. So there's so many levels. When I see patients, I am sure because I have that white coat on and I'm representing a system that has harmed us more than anyone else, I look at them and say, I know you may be scared. Let me tell you why I'm going to do everything I can to help you. Just acknowledging that fear and saying, it actually makes sense that you're scared. And I know that you're scared. And so I'm actually doing something extra to meet you there. That is how you build trust. And it's on us.
And we need more providers that look like you.
Yes.
Because it's one layer off that I have to be concerned with.
Yep.
So let me just expound a little bit on the research study that you're referring to. So in the mental health psychology field or realm, there is we're not totally aligned about the number of generations back that trauma is traced in the DNA, and it's somewhere between 7 and 14 generations of trauma that comes up in our DNA. The phenomenon you're talking about with the smell is just pairing. That's what it is. It's called pairing. And it goes back 7 to 14 generations. So when you think about 7 to 14 generations, you're actually taking us back to the plantation.
Yeah, where were we 7 to 14 generations ago?
Again, our whole existence in this country started off with trauma. No, I don't trust you. And until you can validate my lived experience today, and then at least 7 more generations back, no, I don't trust you, and stop making me the issue here. It's a systemic issue.
And that's why I loved what you were sharing in terms of your approach, that you're acknowledging that up front and really making that connection, because we know there is data that shows when there's racial congruency between the patient and the provider, there are better outcomes. And it doesn't just have to be a doctor. It could be a nurse, a community health worker, a doula. Exactly.
It's all the way around.
Exactly.
Because the studies also show that it's the same in mental health.
Absolutely.
Right.
Because there are things that are happening between me and my African American Black clients. There's an exchange that's happening without me saying a thing.
That shared lived experience.
You know that I understand you just by the way that we're communicating. And it's a thing that you can't learn in school.
Absolutely.
But again, we also need more providers.
Yeah,
Absolutely.
we do.
Absolutely.
And as one of the providers, as wonderful as that is, and I love it, and I definitely know how my patients are affected by that, it also hurts my heart that there might be an idea out there that the only way for me to be safe is to have a Black doctor. That shouldn't be the case.
And it's not.
Right. And the
It's not.
onus, we really need to be calling in our non-Black colleagues to step it up, acknowledge the history, acknowledge the hurt, spend a little more time, do the work to meet your patient where they are.
And understanding.
Right?
I have to say, though, this. I'm not speaking about every provider that is outside of our community. I refer people all the time. There are wonderful providers in all fields and aspects who are not Black that definitely are good, great, have done the work, that are compassionate. And we know that at least we know in the field of psychology that when you're sitting with the client, the number one chief ingredient is going to be empathy. And feeling the safety comes from being in a situation, an atmosphere that is non-judgmental. And that can be achieved by anyone. But I'm sensitive to your judgment. I'm sensitive to it. I'm wired for it. My brain is, and all of us, our brains are wired for survival, not success. And that's even more prevalent in our community. But there are plenty of wonderful providers outside of our
if they
community.
do the work.
When it comes to the systemic issues that you all are all just spoke about, it takes me back to that California statistic that you can be a Black woman who is a high earner, but your chances of survival is much less than white counterparts. Let's talk about that.
Well, thanks for bringing that back up. Because the more I sit with that and try to reflect on what this internal feeling is for me, I think I can, put the hammer on the nail here. I think because income is not the issue, it really goes back to race and the systemic issue. If you remove income, then what is left? I'm not getting the information and the health care because I can't afford it, or I don't have resource, or I don't have the transportation. Now what is it? And these things are real, right? I'm sure that in your line of practice, you have to be able to validate what I'm feeling.
No, absolutely. So I was in residency, OB/GYN residency from 2014 to 2018. The peak of the discussion around Black maternal mortality kind of became more common knowledge in 2016. So I was in training during that time, and I elected to do my resident research on the increased primary cesarean section rate in Black patients. And so I did all of this research looking back at the Black maternal mortality and just what impacts it. When you peel back income, education, obesity, comorbidities, meaning that elevated hypertension, right?
Tell us, girl.
All of those things, you peel them back,
Uh-huh.
the disparity remains. And so when someone in a high-ranking voted, position, for example, says, I'm just going to give you money after you have a baby, as if that solves something, it's not enough. It is not enough, and actually it's a distraction from the actual issue. Yes, there's multiple layers, but if we never actually speak about the racism, if we never call out the bias, we will never have actual equity. And that is the problem.
So Alex talked about the work that she was doing in the community to address postpartum care gaps. Dr. Crawford, or Dr. Sunshine, would love to also hear your perspective on the role that community faith-based organizations have when it comes to navigating healthcare overall, but specifically these postpartum care gaps that we're seeing as well.
Well, I think I want to lead into this discussion by saying historically, in the Black community, the church has always been that beacon of trust.
Yes.
So historically, the church is a trusted space and therefore a safe space because safety comes in trust and in alignment. So the difference between a woman struggling postpartum between the doctor's office or the hospital and the church is that at the church, we are going to ask those questions.
Right.
It's not unusual for the first lady to come, how are you doing following this baby? And, I'm doing okay, because you don't know how to say anything different and you're saying what you think you should say. But a first lady may say, how are you really doing?
That's it.
How are you really doing? I see something here. Are you feeling okay? Because postpartum baby blues, postpartum depression is depression.
Yes.
And it's not unusual for a first lady to say, listen, are you doing the things you love to do? Are you always happy about your bundle of joy? Does it bring you joy? It's okay, sweetheart, if it doesn't. Let me sit and talk with you.
Yes.
And so a church gives you an opportunity to come into a space and not be judged. So a good place to pin this is you can struggle and not be judged. You can ask questions and not feel invalidated.
Yes.
And I like to tap on the whole person because in my field, the mind and body work together.
Yes.
You can't separate the two. The body and the spirit work together.
Yes.
And the spirit kind of helps you understand who you are. So the spirit and identity work together. And I think it's really important. Those are things you just can't get at the hospital.
Yeah.
Right.
So it's important to keep having these conversations in the church.
Yes.
I'm so glad you said that because it's true. The hospital can't solve all the problems and they're not positioned to solve
They're
all
not
the
trained
problems.
to. It's not their job.
It's not their job, right? So there has to be collaboration across industries, across the communities. And while our disparities for maternal mortality persist irrespective of the social determinants of health, we know that there has to be multiple stakeholders coming together
Yes.
to help solve these problems. And so
Absolutely.
the church is a great resource. There's already that trust that you mentioned, and there's other organizations and the communities that maybe are underutilized, but could also be available for community members to get the support they need.
But in that same way, the church can't do it by itself.
Exactly.
Right.
Exactly.
Because, the church can't be the doctor, the psychologist, the physical medicine. It can't do, but the church can be. I'll tell you, I became a part of the First Ladies Health Initiative in 2010, the first year that it was founded in LA. And we discovered some amazing things. I asked people, just do me a favor and find out what your status is today. Just get tested. I know you already know, but just find out today. And the first 2 or 3 years, we were sending people off because blood pressure was up to stroke level. Sugar was so high, they were on borderline diabetes. Some people were already in a danger zone but just didn't know. We folded in HIV trucks and found out that people were testing positive. But the reason why I was able to get them to get the testing is because it's a trusted place. It's a platform. And then we're talking about it from the pulpit.
Yes.
So doing that normalizes the fact that, come on, we do have all of those issues, those medical issues that you talked about.
Yes.
Let's just go ahead and take care of them.
Absolutely.
It's okay.
Yeah.
And leading the charge, me and my husband, the pastor and co-pastor, we're leading, we're showing
Yes.
you. Let's normalize this thing and let's get
Leading
it done.
by example. That's
Yeah,
powerful.
yeah.
And now, Shars, I know you're really active in your church, and your aunt is a first lady.
Yes.
So have you been able to contribute to helping to address some of these gaps within that congregation?
Absolutely. You know, we have our medical ministry, which is fairly small, but should someone need some type of healthcare, even, I mean, someone saying, hey, I have this surgery, I'm actually scared about it. I'm like, oh, okay. And so on Sunday, they might ask me or someone else, you know, about it. My doctor actually goes to my church. I met her through my church. And so when I took my baby to be christened just at the beginning of last month, she was there. I was like, you delivered him. I love this for us, you know. And so it's a true village. And I think the church is uniquely positioned because, you know, we do sometimes go pick folks up and say, well, just come to church. There's a lot less of a stigma and a barrier to just come to church. And then those that my first lady was the one asked me, are you okay? Are you really okay?
Yes.
You know, the elders, you know, one who had 8 children, she said, how are you doing? And just looked at me, and I was like, look at all your knowledge. and just seeing her and her just validating, like there was something in her eyes that said, however you're doing, it's okay.
I love that.
It was the most beautiful thing. And her just holding me with her like soft hands and just saying, and like nodding, like, I know. And look at me.
Yes.
I lived, you know. I said, ooh, I needed that. So yeah, my church has been incredible for me. And so even though I don't know if I've given so much, I personally have received more from my church than I have even given.
That pendulum swings both ways. I remember one of the mothers of the church saying to me, did you ever know you could love so much?
Right.
Did you ever know you could did you know that love had another level?
Yes.
So I know we're talking about postpartum blues, but there's also wonderful parts of it as well.
That's
too.
true.
Yes.
That
And
is
so,
true.
you know, the church taps into all of it.
I agree.
Yeah.
Right. Okay, so next we're going to move on to Tweetable Wisdom, where our guests will give one critical tip to new or expecting mothers. So my question for each of you is, what is one piece of empowering advice you would give to a pregnant Black woman as she's navigating her postpartum care?
As a co-pastor and also as a co-chair of the First Lady's Health Initiative, I think I would love to say that you can be vulnerable and honest and still be holy. So vulnerability and honesty are holy characteristics. You can have faith and still need therapy. You can be strong and still need support. It's okay.
That's great. Well, I'm not a mama. I'm a mamacita. But
Come on,
when that time comes,
That was amazing.
I like
amazing.
when that time comes, I would say ask for the help that you need. It takes a village through the journey of life, and especially in that postpartum phase, you're not going to be able to do everything by yourself. So really tap into your network, tap into the resources in your community, church organizations. Just make sure that you ask for the help you need.
Just to add to that, I love your points. I would say there is no award for suffering, and there is no gold medal for silence. This is not the time to be quiet and to get along. You need to speak up, because you deserve every ounce of help that you could even think of during this time.
That was an amazing discussion, ladies. As we close out today's episode of Our Health Legacy, we've confronted some really difficult truths about the postpartum care gaps and the disparities that Black women face. But more importantly, we've heard some inspiring solutions and pathways to better patient-centered support after childbirth. I want to give a heartfelt thank you to each of our panelists for this crucial and candid discussion. And to our community listening, We hope that you feel informed and empowered. Continue to be assertive and persistent in advocating for your own health needs. And to find more resources and ways to engage, visit us at firstladieshealth.com/maternal health. And help us amplify these voices by sharing this episode with someone who needs to hear it. You can also connect with us and follow us at First Ladies Health on Instagram. This podcast was partially funded through Eugene Washington PCORI Engagement Award. The views, statements, and opinions presented in this podcast are solely the responsibility of the speakers and do not necessarily represent the views of PCORI. This is Taylor Alston, Cleveland, reminding you to pull up a seat with us next time as we continue to center real conversations around maternal health and community care.